Hi, everyone. Welcome to Ask the Egg Whisperer. I'm so happy to be here again tonight answering all of your questions. If you're wondering, how can I get my question answered? Wonder no more. Just go to asktheeggwhisperer.com and then maybe next week I'll get to your question. Right now, I have a whole bunch of questions here, so let's get started. So here we go. Question number 1 is from Elena. Elena says, I had an endometriosis removing surgery in June of 2019 and I didn't get pregnant. Then we started IVF with a long protocol and I got 12 eggs, but only 2 of them made it to a blastocyst. I was overstimulated and we scheduled the transfer for December 1st of 2020. I also had killer cells, which were treated with cortisone. Now I got a negative pregnancy test. What would you do next? How can I help to improve my egg quality? Thank you so much for answering. Elena, great question. I'm sorry you've gone through so much. So let's break it down. Number 1, what is your diagnosis? So let's take a look at your age, which I don't know, but let's ask your doctor, based on your age, what does my IVF pyramid look like? For those of you who are like, what is this IVF pyramid that she's talking about? Go to my IVF checklist article and you'll see the pyramid right there. And you'll talk to your doctor about your hormone levels, your age, and how many cycles you might need to get what you want. Those are the 3 questions I talk to everyone about. What do I want? What is it going to take to get there? And am I willing to do it? You're not going to know how to answer number 2 and 3 unless you know everything about your diagnosis. And in order to know that, you have to know what your pyramid looks like. So since I don't know your age, I don't know exactly how your pyramid's going to look. But what I'm feeling is that the fact that you had 12 eggs and 2 of them made it to blast, guess what? There's hope. And hope means to have only practical and positive expectations. It's kind of hard and kind of annoying to be positive all the time. So we want to be realistic and we still want to have hope in our heart. We also want to talk about the following. What would we do if this next procedure didn't work, right? I have patients that are like, wait. I don't want to talk about that. And I'm like, I get it, but sometimes it feels better to know that there's another option for us later and to pick your mantra and have that mantra perhaps be, I'm going to be a mother one way or another. That rhymes. I just figured that out right now. You would think after all these years of saying that mantra, I would be like, oh, that's really fun and I should make it a jingle. Anyways, until I, quit my day job and go into jingle writing, which I promise you I won't. I'm going to stick to my day job and keep talking about Elena's question. So her question about what I would do next is to repeat your FSH, estradiol, and AMH. And then talk to your doctor about other types of protocols aside from the long Lupron. See why they think you got 2 blastocysts. Was it a lower number of mature eggs? Was the fertilization rate low? Was it sperm driven? Look at all your official reports from your cycle. You can go to embryodiamonds.com and then literally talk to your doctor about each of those elements to come up with a plan. Talk to your doctor about different supplements like CoQ10, adding HGH to your protocol. That's another thing that might help. So I hope that some of these things that I shared with you will be beneficial for you, Elena. And then last but not least, I know I'm never truly done talking about this stuff. Look at the transfer protocol and talk through what kinds of things you want to do ahead of transfer. You gave us a big puzzle piece and a big clue here that you have endometriosis. So I would ask your doctor, have we ruled out adenomyosis, and have we treated the endometriosis enough before our transfer? Great question. This next question is from Hillary, and Hillary says, I'm 40. I've done 3 egg retrievals. The first 2, I got no blasts, and the third one, we added omnitrope, and I got 2 blasts. The first ended in miscarriage at 7 weeks, and we have 1 left that's untested. If it fails, would you suggest doing more retrievals or trying donor eggs, which I'm totally open to do? Not sure when to give up on my own, but also don't want to waste any more time. Hillary, I agree. You've been through so much. You've already done 3 IVF cycles, and to have no blasts the first time with a miscarriage and 1 left that's untested, I certainly can only empathize with all the things that you've gone through up until now. It is a lot. So my suggestion is to prepare for a transfer and let's get that untested embryo home if you're ready for that. However, there still might be an opportunity because you're still obviously making blastocysts to make more embryos. And ask this question and then answer it. Would I rather do an egg donor cycle next and have that work versus try one more time with my own eggs, even if I don't get any blastocysts? If the answer is, in 5 years from now, I might look back and be like, you know what, Hillary, why didn't you do one more cycle? Then I would say, do another cycle. However, if you would say, Hillary, good for you for moving on, then I would say, move on. Since your embryos are untested, one little tidbit or pearl, I would like to call it, that I'll share with you is, don't just assume that the reason why you're not making blastocysts or that you had the miscarriage is because of your age. I would certainly look at all the other reasons for miscarriage and look closely at my angel workup or angel method and talk to your doctor about those things and see what they think about checking different things for you. Each pregnancy is an opportunity for you to learn about your body and what's going on. And what I mean by that is if you test a pregnancy and find out it has abnormal chromosomes, then that tells you a story. If you have a pregnancy that ends and you test it and it has normal chromosomes, then it also tells you another story. So your doctor would be able to put everything together for you and come up with a really good plan. And that's why I share these things, because of all the experiences I've had and patients just like you who've gone through 3 cycles. And that's how I would guide you if you were a patient of mine. This next question is from Maricela. I'm 33. I've had 5 pregnancies and 5 miscarriages. They all happened around 5 to 6 weeks, and I've never been able to hear a heartbeat. The furthest I've gotten to is a yolk sac. The doctors wouldn't tell me until after my 3rd miscarriage. When that happened, I was told my ovaries were old, and I think that's what she meant, that the doctors never told her these facts. My AMH was low at 0.79. Right after that, I was also diagnosed with cervical cancer, and it was devastating news. They were asking me to remove my uterus, but I couldn't do it. I had 2 cone biopsies, got pregnant 2 times after, but I miscarried both times. In my pain and frustration about the cost of infertility, I went out of the country for treatment. The doctor retrieved 3 eggs, and I just want to advise on what to ask. What should I try to do to make my body more receptive? I hope to be able to go back to do IVF. What do you suggest I do to help me? I can get pregnant. I just can't keep them. Can you give me specific advice that I should be asking? So Maricela, I would say you were exposed to something that caused the cervical cancer, and that is basically what we call HPV. That exposure might have affected your fallopian tubes. The fallopian tubes, if they're dilated and filled with fluid, could potentially reduce your implantation potential. So that's one thing I'm thinking in a situation of yours. The second thing I'm thinking is, have you had a complete recurrent pregnancy loss workup? If you haven't, I would make sure that you get it done. It sounds like you already know that age, probably not your age, I mean, you're young, but your AMH might be part of the story. But let's not forget about ruling out antiphospholipid antibody syndrome, a uterine septum, and at the end of the day, did those cones cause some sort of scarring? Is there something inside your uterus that we need to understand a little bit better? I would be very nervous, given everything that you've been through, if there's one chance for you to have a genetic pregnancy, right? Meaning your DNA. I would say, look, you've had 5 miscarriages, you have this diagnosis of cervical cancer, and I know you don't want to have your uterus removed, but maybe it might make sense to consider a surrogate. But talk to a GYN oncologist and see what they think as well. So those are kind of my tidbits. But if you were a patient of mine, we would also be doing implantation testing before transfer, looking at the sperm, making sure the sperm is super sparkly. Today is not just a sparkle day, it's a super sparkly day. We got to bring it up a notch when talking about this kind of stuff. So I hope that helps. This next question is from Mala. Mala says, I started IVF at age 39. I did a long cycle and I got 2 eggs and 1 blastocyst. I did another short cycle and got 9 eggs, 6 blastocysts, and froze 4. I did another cycle, got 11 eggs, got 2 blastocysts. They were all day 5. My consultant did not recommend testing or ERA. From all the fresh transfers and 1 frozen, negative pregnancy test for everything. I changed my doctor, who then recommended PGS testing, the 3 left that were frozen, from which 1 was normal. I did the ERA after watching your show to find out I needed a transfer a day later. I got pregnant at 42 with a tested embryo, but had a medical miscarriage as the embryo didn't grow and no yolk sac or fetal pole was seen. Dr. Aimee, what do you recommend for me, please? I've had Tushy and balls checked and both had chromosome tests, which were normal. So Mala, the other test that I would also do is to look at silent endometriosis. Is that playing a role here? Even if you do the test, sometimes it might be something to think about as far as just treating as if it's there. Not all tests are perfect. Even if a test is negative, doesn't mean it's not there. So talk to your doctor about, have you ruled out adenomyosis? Have you ruled out endometriosis? Have you done a complete preconception panel? Have we looked at the cavity of my uterus? Okay. Have you ruled out antiphospholipid antibody syndrome? Was DNA fragmentation, if it was abnormal, possibly playing a role in this miscarriage? And how is my embryo quality? So there's this assumption that any embryo, even if it has normal chromosomes, can stick and grow, right? Just as long as it's normal, the quality doesn't matter. See, the quality does matter. And talking to your doctor about whether quality played a role, I think would be helpful. So I hope that helps, Mala. Okay, this next question is from Alexis. Alexis says, Dr. Aimee, my FET was canceled last month due to my uterine lining being 7 millimeters. During the retrieval, it got up to 12. My doctor and I agreed to wait a month to cut my dose of letrozole in half to 2.5 milligrams. This way, the follicle could grow slower and give the lining more time to grow. I'm not taking any medication right now other than letrozole, prenatal, and CoQ10. Is there anything I can do to help thicken my lining? Thank you for being a voice for this community. Alexis, great question. So this is the question I have for you. How large does the follicle get? So maybe you're waiting not long enough. So maybe wait till the follicle is 20 to 22 millimeters, and that will give you the lining that you need. As long as your hormones are nice and low, and what I'm referring to is the progesterone level, it could still be a good transfer cycle. I tend not to do natural cycle transfers as much, just because I like things to be planned, coordinated, and like perfect. I don't like surprises like, oh, you've ovulated, or oh, the IVF lab isn't open on the day that you need to do your transfer. Like those kinds of things annoy me like slightly, and that's an understatement. But my thought process is, if you're not getting your lining thick enough on the Premature protocol, we know you make a good lining because you just said that your lining gets to 12 millimeters during stim. So maybe consider a controlled cycle, see what your doctor thinks, and take estrogen for 2 weeks, do a lining check, see how it looks, and then take estrogen and progesterone for about 6 days until your transfer. And then talk to your doctor about the E of the Egg Whisperer diet. Diagnosis, IVF, endometrial receptivity testing or embryo transfer preparation, and then do the T, which is the transfer. This next question is from Allison. Allison says, what is the typical treatment for adenomyosis? I have moderate adenomyosis and stage 4 endometriosis. I suffered a miscarriage and chemical pregnancy with my only 2 embryos, looking for a next step. Thank you. Okay, Allison, so talk to your doctor about how severe is your adeno. Is it moderate? Is it severe? What realistically is the expectation that your uterus will be able to carry a pregnancy beyond viability without having you suffer great devastation? And what I mean by that is adenomyosis can be pretty terrible in a lot of cases. So if it's severe adenomyosis, you want to know that up front. Despite treatment with, let's say, Lupron and letrozole and agestin and all the anti-inflammatory stuff like taking N-Acetyl Cysteine, despite all of that, sometimes still you can't overcome the adenomyosis. So if you haven't had surgery, and it sounds like you have because you already know the stage of your endometriosis, consider laparoscopy. I would consider Lupron or Orilissa. That's another form of a similar type of medication that does the same thing for 1 to 3 months, depending on the severity. I would definitely consider also taking Premature concurrently at the same time if you can tolerate all the side effects, and then take agestin about 2.5 milligrams. Look at your body size, look at your nutritional status, and do everything you can do to optimize everything and get into the best shape of your life, because my goodness, you're going to need so many coping strategies to get through what some of these medications can do to you, both psychologically and physically. So I hope this answer is helpful, but at the end of the day, I think also meeting with an endometriosis specialist could be extremely helpful and informative for you before you make your next decision as to what you're going to do next. And I really hope your next egg retrieval is fantastic and you make ridiculously gorgeous embryos with this next egg retrieval. And I wish you well. This next question is from Amanda. Amanda says, hi, Dr. Aimee. First off, I love watching your shows. Thank you for all you do for us. I'm 31 years old. My AMH is 0.6, and I have currently done 3 egg retrievals and 3 transfers. None of them have worked. I just had a big negative and 2 chemicals. My protocol has been the same each round, priming with ganirelix and estradiol patches and stimming with 450 gonal F-follistin, 150 Menopur, Omnitrope, and microdose Lupron. First round got 0 blasts, second round 4 blasts, and third round 0 blasts. I just don't understand. I've been hearing low-dose HCG works better than Menopur. What are your thoughts on that? I'll be starting the year with an endometrial biopsy, then doing another egg retrieval since I only have 2 frozen embryos that are untested. Doctor says at my age, PGS testing really isn't necessary. What are your thoughts? A year and a half later and still nothing to show for it. Any help and suggestions are greatly appreciated. Thank you. Okay, Amanda, here's the deal. We kind of know your diagnosis, right? So let's just start with the basics. The diagnosis is you're 31 years old and your AMH is low and we're having embryo quality issues, right? That's how we talk about it. When you're not even making embryos that reach the blastocyst stage, you can assume that the other embryos are lower quality, right? They stop growing. An embryo has to do with an egg and a sperm, and it has to do when it comes to the quality with your age, genetics, and environment. We know your age is young. We know your genetics? No. Let's talk about that. Fragile X chromosome analysis for both of you. As far as your environment, look at everything in your life as far as what you can do to lead the healthiest and have the healthiest lifestyle. Look at the supplement list that I often talk about. The CoQ10, the NAD, the pterostilbene, for example, making sure you're on a really good prenatal with vitamin D. Even if you're not deficient, then you don't need it. Fish oil, for example. So those are the kinds of things that you guys hear me say over and over again. And the reason why I say that is because I don't want people to take 3,000 things. And sometimes I see these lists I'm on vitamin E and L-arginine, and I'm taking maca and I'm doing DHEA. And I'm like, I don't know that you really need all of that stuff. So I try and keep it as simple as possible. So also look at sperm, right? So what do the official reports look like for you? What is the sperm quality? Does it make sense to do a sperm DNA fragmentation test? Can you introduce different technologies in the lab to make the sperm sparkle even more? See, every time I say sperm sparkle, you have to take a shot of something. For me, it's a shot of my coffee right here. Do you see my little unicorn dancing on a pole? I get lots of fun gifts, and that was recently one of them. I have fun drinking from it. I can't drink from anything else right now. So back to your question, Amanda. I would consider having you and your husband do a chromosome analysis. I would take all the supplements, talk about HGH, and then you still have, I think you said, an embryo. You have 2 frozen embryos untested. I have had patients just like you who still choose not to test the embryos, even though I'm like, it makes sense to test them. And they're like, I don't want to. And I'm like, your priorities are mine. We're going to not test them. And I still go through all the same testing. I still do the ERA and Receptiva DX tests, and I still move forward. And I'm still as picky with everything as I always am. And then we go ahead and plan your transfer. So I would say, based on your age, you've already gone through the number of cycles that you've gone through, maybe consider doing it again. But the 2 chemical pregnancies, I know I keep talking, I get really excited about this kind of stuff as far as how I can guide people. But remember that my advice is not to replace the advice from your fertility doctor. I'm just here to share things so you know what questions to ask. That's all. But your 2 chemicals are shouting to me, pay attention to me. Have you looked at the fallopian tubes? Have you gone through the Angel Method, that workup that I have online? You can just go to angelmethod.com and you can see all the little things that are there. So I hope this really helps, and I wish you all the best. This next question is from Graham. Graham says, when doing the Lupron protocol for endometriosis with IVF and ICSI, how long do your patients usually do the daily Lupron shots? So Graham, there's Lupron and there's Depo-Lupron. So the Lupron daily shots can be every single day until the progesterone start. So that's subcutaneous Lupron in the skin of your tummy. Most patients tolerate that very well. They don't feel like they need an intervention. They don't need to feel like they have all these coping strategies in place way ahead of time for everything that could possibly happen and how they feel. However, Depo-Lupron, different story. That drug is evil. And if you didn't know how evil it was before you started it, you might wish you hadn't started it. So I typically, when I recommend it, I often know who I really want to take it and who I don't want to take it. So patients who shouldn't take the Depo-Lupron version are people who have problems with depression and anxiety, right? So if you're tearful all the time, if you have a hard time sleeping, if you have a hard time just coping with everything right now, I promise you Depo-Lupron will not make things better. However, if you have good coping strategies, you have a good social network, you have friends that you can complain to about like how awful being a fertility patient is right now with COVID and everything that's going on, and then you have to take this shot that's really horrible, and you can whine to all your friends and have them be like, girl, I got you. Just keep on talking. I'll be listening with my ears and not my mouth. Like those are the kinds of friends you want when you're on Depo Lupron. Okay. This next question is from AR. I'll just call you R. I'm just kidding. I have a feeling your name is not R. AR. Okay. Age 40. AMH 1.5. AFC 10. Cycle 1. Oh, AR is very efficient. Here we go. Cycle 1 canceled due to a lead follicle. It was the antagonist cycle. Cycle 2, microdose Lupron flare, 6 blasts, 5 abnormal, 1 mosaic. Okay. Cycle 3, 3 blasts, 1 normal. Cycle 4, 6 blasts, 5 abnormal, 1 mosaic. Taking ubiquinol, mild inositol, NAD, vitamin C, D, and E. Only want 1 child. Suggestions on what would you do if the transfer fails? Mini IVF, fresh transfer without testing, second opinion. I'm in a state where they will not give me HGH. Could stim meds be damaging my eggs? My estrogen plateaus toward the end of stimulation. Okay. AR, you're doing pretty darn well. You've done 4 cycles, 1 normal, and 2 mosaics. A lot of people who are 40 do 4 cycles, 0 normals, and 0 mosaics. I'd say, let's take a look and see. What is the quality of your normal embryo? Is it time to stop? Okay? So talk to your doctor about your official reports and see if it's time to stop. Because if you want 1 child, it sounds like you might be in good position to have that. If you're feeling, though, that you might change your mind and you might want 1 more baby, then perhaps consider trying again, okay? I would say do the protocol that you got the 1 normal in. I'm not sure that you really need to change anything. You are making blastocysts. It's like flip of a coin whether that blastocyst is going to be genetically normal or not. At the age of 40, I think it's around 25% that each blastocyst will be chromosomally normal. By the time you're closer to 42, it's about 15% that each blastocyst will be chromosomally normal, right? And so the fact that you're making blasts with the protocol that you're on makes me feel like, and especially because you got 1 normal in cycle number 3, I wouldn't necessarily feel like I need to change anything. I would say it might be time to talk through, like, how does embryo transfer preparation look? Because if you start the embryo transfer preparation, you find out, for example, that you might need to do more work to get ready for transfer, like take Depo Lupron for 1 to 3 months. At that point, you might want to do another cycle. Because now you're looking at doing another cycle if that transfer doesn't work, maybe 4 months, maybe 6 months later, and that might be too late. So I would highly suggest talking through embryo transfer preparation right now and maybe forego doing another cycle because you've already done 4. Well, you've done 3. The first one feels like a cycle, even though it's canceled. I get it. Okay, this next question is from Nisha. Nisha is saying, hi, Dr. Aimee. I'm back again with more questions. Hi, Nisha. I'm the one who needed a second ERA. I had 1 child 7 years ago naturally and easily at the age of 32. After trying for number 2, we learned my tubes are blocked from scar tissue from my C-section. You mentioned recently that that is rare. And it's true, Nisha. Having scar tissue from a C-section is super rare. It happens, but it's rare. During my IVF process, we found out also that I have low AMH. After 2 egg retrievals, I only have 1 normal embryo. I'm sorry, Nisha. You're now, oh, no, you're 39. That's pretty awesome. I was going to say, I thought you were 32 for a second there, but 39, we're doing pretty well here. She said that she cannot retrieve anything else from me because now I'm in premature ovarian failure. I just don't believe it's true. I believe it's just not going to be easy. Do you agree with her? One more question. How do I explain the desire to exclude birth control pills from a medicated FET cycle? She definitely does not agree, and I hate the pill. Thank you. Okay, let's break this down. As far as your diagnosis of premature ovarian failure, it basically means that you have an FSH of 40 or above. Do you? You might have decreased ovarian reserve, and honestly, everyone who's 39 pretty much, like probably 70% of people, get that diagnosis of decreased ovarian reserve just because of being 39. So I would focus on your AMH and your follicle count. I wouldn't focus so much on labeling yourself as premature ovarian failure. I feel like there should be no medical diagnosis that we use that has the word failure in it. It just doesn't seem right, right? We don't talk to humans and be like, you have this failure. I would say you have premature, your ovaries, I say they're taking a break right now. It could be a permanent break. They're on vacation. We'll see. So let's track and trend your levels. Let's see what's going on. Let's ride the wave. And what I mean by the wave, I mean by the wave of follicles. And when a nice wave comes in, you just jump on that wave. and see how it feels and surf it out. Go to that beach. Ha! I clearly, again, should keep my day job because these analogies, they're super cheesy today. On the cheese factor, out of 10, I'm like, out of 10. But I kind of like this wave analogy, right? Right? I think you guys are out there listening and saying, Aimee needs to go to the beach. And I actually do. I surround myself in my office. I don't know if you can see the pictures of the beach. And patients come in pre-COVID and they're like, oh, do you like to surf? And I'm like, sure. I actually love to work. So please don't ask me where that picture was taken because I have no idea. Okay, so the other question about your desire to exclude the birth control pill, guess what? You have free choice. You get to say no. You can just say, I don't want it. It's as easy as that. Like, you don't need the birth control pill to do a medicated frozen embryo transfer cycle. Birth control pills, from my standpoint, disgusting. Would I take them for a frozen embryo transfer? If you told me I had to, I'd put up with them for like no more than 10 days, but then I would honestly probably be like puking every day because I can't tolerate them. And my husband would have to like move out to the man cave. We actually have a man cave for all the partners in my, I should call it a partner cave. I joke and say, like, once you start IVF with me, you get the address for the man cave, and then you can come back when it comes time for semen collection. No, there's no such thing as a man cave. There should be like a woman cave where we go, you know, like in some countries, like after you deliver a baby, you go for like 30 days and they like take care of you and they like feed you and you just like open your mouth and like put grapes in your mouth that are peeled. Wouldn't that be awesome and amazing if like we go through IVF and it's like the same thing? We go somewhere, like I dream about creating that like top type of experience for people where you go and like everything's done for you. You just walk in and then like they give you a massage as you're getting your blood drawn. And then like while you're asleep for the egg retrieval, they're like painting your toes. Maybe these are dreams of mine that I have. Like while I'm doing my egg retrievals, I'm also getting pedicures at the same time. I actually joke with my patients as they're going to sleep. I say, have you picked out your color? Because when you wake up, because you can't go to a beauty salon right now because of COVID, you'll wake up with the nails of your choice. You can tell I don't do my nails. I don't, obviously, because I'm a doctor and I'm always washing my hands and I have to keep nice, clean nails. Okay. Not that having nail polish means they're not clean. You know what I mean. Okay, next question. That was a fun question, Nisha. Thanks for sending it in again. Or another one again. This question's from Laura. I see that you recommend supplementing with NAD for egg quality. What do you think about NMN? And any research you've read? And I would say yes to NMN. My thing is, I don't want my patients to be on a boatload of stuff. So I'm like, pick one. NAD is great. NMN is also great. They probably can do similar things. Do you recommend systemic enzymes for people who have endometriosis and have had excision laparoscopy in December? Should I consider using Orlissa before transfer, even though I just had a laparoscopy, or just do a natural transfer cycle using letrozole? I have DOR, so not many untested embryos. Do you recommend anything to prevent regrowth? Before my surgery, I had 3 failed transfers with no implantation. I'm 44 since July, and I'm contemplating to do 1 or 2 more cycles before another transfer. Thank you. So Laura, get on the NMN, get on the NAD, get on the HGH, get on the everything. Okay, get on your Peloton. No, that's not what I meant. And do your cycles now. Do them now. Don't do them later. If you're going to do 1 or 2 more, this is the time. And then do implantation testing. The Receptiva DX test can tell you basically how, I'll just tell you how I use the test, just because this is how I use the test doesn't mean everyone uses the test this way. What I do is I do the test and I take a look at the results and I let the results guide me as far as how long and how much depot Lupron I think you might need before we transfer. And the thing is, given your age of 44, the last thing I would want to do is to put you on 3 months of depot Lupron and then have you say, I'm ready to do another cycle. And I'd be like, no. We should have done that before the depot Lupron. So that's why it's super important to do cycle planning, create this roadmap. And obviously we all know that there are bumps in the road along the way. And hopefully in your case, you will be successful because it would be super awesome. I mean, I really get, again, clearly this face is always ridiculously excited about helping everybody. But anytime I can push the limits, especially when it comes to age and fertility, it's like pretty awesome. And so I hope that, one day it'll be like, oh, you're 44. Yeah, come on in. The chances are really good. Unfortunately, right now it's like, oh, you're 44. Your chances are really low. But let's try and see what's going to happen, because low does not mean no. And eventually it's going to be 0 for everybody, unless you are, I don't know who. There's no one out there where the results that it's not 0 at some point. Okay, this next question is from Jaleesa. Jaleesa says, hi, Dr. Aimee. I had both my tubes removed due to hydrosalpinges. For those of you guys who don't know what that means, hydro water salpinges tubes. So it's water in the tubes, they're bloated and blocked. Do you no, let's go here. They drained a large benign cyst on my right ovary at the same time. I'm on a wait list for IVF now. I'm super nervous for the cyst to return and prevent me from starting IVF. Is there anything I can do to keep the cyst from returning? Can IVF be done if the cyst does return? Thank you. The cyst, ask them, is it part of my ovary or is it a collection of fluid within scar tissue? So if the cyst is small and your estrogen is low, go for it. You don't need to wait if your follicle count is good. If the cyst grows back and your estrogen level is high, it's going to muck things up. It's going to be all mucky and yucky. So talk to your doctor about these things. Check your hormone levels on the day you go back in, and if the hormone levels are low despite having a cyst and the follicle count is good, go for it. If, however, the estrogen level is high, the follicle count is low, and the cyst is there, wait for it. I can tell you, starting a cycle and finishing off and have it be pretty crappy sucks, okay? It is not the experience I want people to have. However, dealing with a delay, that's a lot better. I mean, it still does suck, but not as bad as going through a cycle that doesn't work. As far as doing something to keep the cyst from returning, I mean, the cyst usually comes from ovulating. And one thing you can do, you guys know, I just talked about how I puke on birth control pills, is to consider birth control pill starts or consider a mid-luteal phase start. So remember that wave that I talked about? Ride the wave, see how the eggs look after ovulation, and start your meds then. As long as you have eggs, you can start IVF stim. The issue, though, with the mid-luteal stimulation is this. You can't use FSH estradiol to guide you about your egg quality. You don't have the option to convert to an IUI if the cycle isn't good, and you can't do a fresh embryo transfer, it seems, because the lining is just not receptive at that time for you to do a transfer. So you have to commit to a frozen embryo transfer and freeze the embryos for later when your lining is ready. Okay, this next question is from Crystal. Hi, my husband and I both love listening to you. He said, you sound like you actually know what you're talking about. I think I do. However, I think I sound like someone who loves talking about this, like totally overboard. You know, I just came out of the womb being like, who wants to have a baby? And right now I'm like, I need to fill this world up with as many loving parents as humanly possible before I leave. And God knows where I'm going to leave, but I have no plans of leaving anytime soon. So my work is not done. Here we go. I'm 36, he's 30. I have 2 kids from a previous marriage. We've had 4 miscarriages in the last 2 years and 3 failed IVF transfers. Our embryos were never tested, but they were good quality 8-cell day 3 embryos. If my egg quality was bad, would we still make good quality embryos? Could it be a lining issue? If so, what could I take? Is it worth seeing an immunologist? I have no signs of endometriosis, and my husband's semen analysis was perfect. I feel so defeated. My AMH is 0.54, but every other test so far has been normal, including a hysteroscopy. Okay, Crystal, let's break it down. Here we go. You're 36. You're young. Believe me. You're almost 10 years younger than me. You're a baby to me. But the reality is your ovaries, different story. We're used to people showing up at the IVF clinic being like, I'm ready. I feel so young. And the answer is you are. Like, I don't want to take that away from you, but your ovaries with your AMH at 0.5, they're telling us something different. And embryos are like diamonds, right? In that when they're beautiful on the outside, that usually means they have high value if you're a diamond and the implantation level and rate is high. However, unlike diamonds, you don't just look in the inside of an embryo with a microscope and see the genetic integrity. So the genetic integrity is something that's really important for us to realize has everything to do with whether an embryo is going to stick and grow. So while you have not done any genetic testing of your embryos, I'm not saying you have to do it, but I feel like the most obvious things should be ruled out first. So the most obvious things in your situation are chromosome analysis for you and your husband. Do a carrier screen just to see if you're a carrier for factor V Leiden, for example. Still do all the stuff in the Angel workup. But I would say in your case, especially with the miscarriages that you had, I do think that considering PGTA testing could be extremely valuable for you so that you can have hopefully the information. So you don't start going, what do they call it, that rabbit hole where you're looking at everything and I would rather just focus on the things that are super obvious as far as like what could be the problem here. Okay, so next question is from April. Hi, Dr. Aimee. Today I'm having my lining scan and I have brown old blood in my cervical mucus. Not heaps, but definitely there. I'm assuming this means that I have old blood in my uterus again. Here's the thing. I had a hysteroscopy on December 18th and went straight into estrogen, a double dose, 100 milligrams a day. In October and November, after my fresh transfer, both of those got canceled on lining day as well due to blood in my uterus. Everything looked normal at my hysteroscopy, apart from some scarring due to adenomyosis. My blood the day before hysteroscopy were all still super low. I had 3 months of Zoladex shot in June. My question is, what the beep is going on with my body? Okay, April, this is the thing. You might have scarring in that uterus of yours. I would get a hysteroscopy. Take a look in. That fluid collection that you had described to you, it may not be blood. It could just be fluid that's trapped there by a band of scar tissue that you can't see with your eyes. So you can always start off with a saline infusion sonogram, and if your doctor is suspicious of anything, then go to a hysteroscopy and do that. The Zoladex, it sounds like your doctor knows, actually, you know what? Let's back up here. April, you already told me everything looked normal at hysteroscopy, aside from some scarring due to adenomyosis. Go back. You got to look again, my friend. That is what I would do. So go back, do it again. I've had patients who've needed 3 hysteroscopies because of little amounts of scar tissue that they see in the cavity of the uterus that just aren't going away. And there are different strategies to hysteroscopy where you can put something called a uterine stent. It's just like this cute little balloon. You put it in the uterus, and I can tell you, you don't feel super cute after it's in there. It hurts like hell for some people. Hurts like heck for some people. Shh. Don't tell anyone I just said that. And then you can have it removed. So that might be something to consider. And then talk to your doctor about how severe your adenomyosis really is and get just very clear answers about statistics and chances of how high your implantation rate could be with the adenomyosis that you have. So you have the opportunity to do everything you can to create more embryos and transfer and see whether you should be transferring to you or consider other options, because the adenomyosis might be so severe, and maybe, I'm not saying this is happening, they might be too afraid to tell you exactly how high or how bad the adenomyosis is. So that's something that I would consider talking to your doc about. Okay, this next question is from Emily. Hi, Dr. Aimee. Thank you for your show. I love what you do for us all. I'm 37. My AMH is 1.14, 6 follicles, FSH 5.8. I'm concerned for one almond-sized fibroid near the uterine lining in the uterus and a cyst on one ovary. Do the fibroid and cyst need to be removed before IUI or IVF? My partner's sperm has not been tested yet, and he does have a varicocele. I'm so nervous. I'm willing to go to all lengths to have a child, but he won't. I'm so scared he won't be willing to do IVF. Do you have recommendations on how to navigate the decision? I do. And it's easy. You don't need a man to have a baby, right? Men have this luxury. They can be 37 and not have to worry about it. But guess what? For us at 37, we have to worry about it, because by the time we're 39, 40, 42, at 44, we're talking about a less than 5% chance of pregnancy. Eventually, our chances will run out to have a baby with our own DNA. He doesn't have to worry about that. That's not going to happen to him. Sure, things change as guys age as far as their risk for having a baby with some abnormalities, but for the most part, it all falls on us, okay? So remember my 3 questions. What do you want? What is it going to take? Are you willing to do it? You want a baby. What is it going to take? Having a partner that's willing to be a participant. And if he's not willing to be a participant and you still want what you want, are you willing to move on? Don't allow him. Have so much respect for yourself. Life is so darn short. Because I can tell you, if you end up having a baby with him and it feels like the wrong decision and you guys are fighting, you didn't go into this relationship wanting to care for your baby 50% of the time and splitting custody. Make sure you've gone through all the counseling possible now, okay? So if you have to twist someone's arm and be like, please have a baby with me, trust me, when you have that baby, they're not going to be as helpful or as supportive as a parent than if you have someone that's like, Emily, what can I do for you? How can I help you? What do you need? Like, that's the kind of support I want you to have and what every woman deserves. And if you can't get that, trust me, doing it on your own will be way more better. WMB, way more better. I just made hashtag way more better. I just made that up right now. Okay, but back to your medical. I know you didn't need a lecture from Auntie Aimee. I'm kind of like your big sister, not quite your aunt. Maybe in like 20 years I'll be your aunt. But Auntie Aimee is saying, listen to me, Emily. Okay, so as far as your one almond-sized fibroid near the uterine lining in the uterus, yes, we want that out. So schedule yourself a hysteroscopy with a great surgeon. Hysteroscopy sounds scary, but it's basically a small camera that goes in the uterus and they shave the fibroid out. As far as the cyst, ask your doctor what kind of cyst they think it is. Is it just a cyst from ovulating, meaning like the benign kind that come and go? Is it an endometriosis cyst? And those collections, sometimes they can cause egg quality to be lower, or they can, if they're secreting lots of inflammatory cells, can reduce your implantation rate. And that's called an endometrioma. So talk to your doctor about that. And then if it's the cyst that comes and goes, like you'll know by doing a follow-up ultrasound. If it's a cyst that stays, your doctor can usually tell based on the texture of the cyst fluid color on that ultrasound screen what kind of cyst it is. So then you'll know whether it needs to stay or go. And then last but not least, as far as your partner and his varicocele, yeah, I mean, I would say he can do a sperm test. Meetfellow.com/egg-whisperer. Do-it-yourself test, super easy to order and do. So I would suggest that he does that. And then if he's like resisting, you'd be like, hasta la vista, baby. I'm moving on. I'm going to seattlespermbank.com and I don't need you. Okay, I'm having too much fun today with that one. Okay, this next question is from Sash. I'm currently going through IVF treatment and awaiting my embryo transfer date. I can't get a date until I start my period and medication. My question is this: is it likely that your cycle can be delayed due to IVF as mine are late by 3 days? And the answer is, Sash, totally. So when you go through IVF and you're on all these medications, what happens, right? You make cysts, right? You drain the fluid, and for the most part, the cysts go away, but sometimes they fill back up with fluid, and sometimes they start secreting a little bit of hormones, and that prevents your period from coming like exactly when you expect it to. So if it's a little bit late, it's totally okay. But if it's a lot late, go on into your doctor, get a checkup, do an ultrasound, check some hormone levels, and you'll get an answer as to what's going on. And then you don't have to worry about things that like can make you feel like something might be wrong when it's really not. Next question is from Bharati. I had one kid 4 years back with no issues. I'm 32 years old and having a hard time conceiving for 1 year now. I have lean PCOS. I'm 110 pounds, 5 foot 3 inches. My TSH is 2.8. My TPO antibody is 57. I have Hashimoto's. I have a low T3 and T4 to T3 conversion issue, and I have irregular periods for the last 1 year and adrenal fatigue. Before that, I had regular periods. My AMH is 13, LH 17, FSH 5, estradiol 31, prolactin 13. Other values: insulin 4.9, hemoglobin A1C 4.7, ferritin 80. I've been on, here we go, Synthroid 25, Cytomel 10, Metformin 1000, supplements including NAC, Ovasitol, CoQ10, Theracurmin. I tried letrozole 10 milligrams for 2 cycles with trigger and acupuncture, didn't get pregnant, no sperm issues for my husband. I've been vegan and gluten-free, doing the HSG next cycle. Is IVF the best option? What would be your treatment approach? Root cause? What are the supplements to take? Any endocrinologist you recommend in the Bay Area? T3 med, yay or nay? Okay, let's break this down. First question is, you've been trying for 1 year. You have one baby already, and your egg reserves, your egg counts seem really fabulous. Could this be related to your TSH? I'm not sure. Your TSH is at 2.8, which is pretty darn good. I love Dr. Jyoti Bhatt, B-H-A-T. She's with Jiva, J-I-V-A health.com. She's fabulous. Everything's telemedicine right now, so you can call her and say, Aimee sent you. I'm just kidding. You can't say that. Have your doctor send a referral to her. And then, yeah, I mean, I do think that doing an HSG makes perfect sense. Even if you have one baby already, that just means that one fallopian tube at that time was open. We can't confirm that both are open now. Maybe one is open, one isn't. And maybe with the Femera cycles, you ovulated on the block side both times. So I do think doing a HSG makes sense. I think that looking at sperm very closely, it looks like you did the sperm test, but no issues. Look again, do a careful look at the morphology of the sperm and make sure that he's doing everything to make his sperm sparkle. See, I said it. You guys were waiting for it. And there, I said it. As far as the Femera cycles that you were doing, let's see here. You did it with a trigger shot. I would say maybe add IUI. That's something that I would consider doing before you did IVF. And as far as T3, I would talk to a medical endocrinologist. I don't get into the adjusting of Synthroid and Cytomel, but I do know that there are some fabulous endocrinologists that totally do that, and I would support that as well, given the levels that you shared with me. So my suggestion is Femera with IUI, and the fact that you have you have not been successful yet, even though you've tried for a year with your irregular cycles, I still think it's worth doing at least 1 or 2 Femera IUI cycles before you consider IVF. Get your tubes checked, look closely at the sperm morphology, and see what you can to optimize your chances before you go to IVF. And you guys are probably like, wait, what? Isn't she an IVF doctor? Like, why is she not saying do IVF? Isn't that one of the Egg Whisperer golden rules if you're 32 years old to do IVF? And the answer is no. Egg Whisperer golden rule number 3422 is this. If you're 32 years old and you want 2 kids and you don't already have one at home, do something to preserve your fertility. Either freezing eggs, freezing embryos, or do both. And in your case, you have 1 baby at home, you have really good ovarian reserve levels, sperm sounds good, no tube check yet, let's get that checked, and then obviously go through my Tushy method, do the Y, which is your chromosomes and genetic profiling with the gene, recessive gene testing, and then go for it. And give yourself a timeline. Be like, hey, if we're not pregnant in 6 months, then we'll do IVF. Okay, great. So this next question is from Ella. Ella says, my doctors give the HCG trigger shot right after IUI. Just kidding. Is this okay? I've done the IUI on cycle day 12 twice and it failed. Could this be the reason for the failures? Okay, guys, let's break down the trigger shot. Trigger shot sounds like a very violent thing, right? I'm going to give you the trigger shot. It feels like someone's going to take a gun and blast you across the room. And the answer is no. It should be called like the sprinkle shot or the egg gently launching shot. Okay, it's a tiny needle skin of your tummy and it induces ovulation. And the reason why we give it is to time insemination or intercourse. Have I ever given it after an IUI? I can't really think of a time that I've had a patient come in after the IUI and give it. I've had situations where the patient had a positive OPK the night before, they come in the next day for the IUI, and the husband is out of town, and he's going to be back. Like, I'm just trying to think of a scenario. I can't even think of a scenario when I've given it after the IUI. So I would say maybe ask your doctor, why did you give it to me after the IUI? However, in some parts of the world, they use HCG as a supplement similar to progesterone. So there are some people who do HCG shots after the IUI to kind of mimic progesterone. I mean, that is a thing, so that there's nothing wrong with that. But as far as giving a trigger shot dose after the IUI, I imagine they're probably doing it. They're trying to be more creative than I am right now. I use just progesterone, but there are definitely reasons to do HCG after the IUI that aren't totally nutso, right? So doing the trigger shot after the IUI could be a totally normal way of supplementing with progesterone for at least 7 to 10 days, because that's how long it could be in your system, rather than taking progesterone supplements. This last question, before I get to your live chatted questions, is from Lindsay. Lindsay says, hi, Dr. Aimee. Thank you for all you do in answering my question. I'm 37 with an endometriosis diagnosis. Not surgically, but I have several large endometriomas on my ovaries. I've had 4 failed IUIs and recently had a failed FET with 2 PGS tested embryos transferred at once. After 2 egg retrievals, we only had 2 PGS embryos. I had a chemical pregnancy with my HCG measuring 22 on day 9 and then an HCG of 4 on day 14. Why did PGS embryos result in a chemical pregnancy? I thought chromosomal abnormalities were the cause of chemical pregnancy. My protocol for the FET was 2 months of Lupron for PrEP and then Pepsid Claritin intralipid infusion as well. What do I do next? We are desperate to start our family. We would love to have 2 children. How do we get there? Please help us. Lindsay, my heart goes out to you. You're doing and asking all the right things. I would go ahead and do more IVF cycles. Talk to your doctor about your protocol. Talk to them in detail about all the embryo diamond stuff that we talked about. Learn about the quality, what you can do to support the quality, what your diagnosis is. And it sounds like we know everything. We know your age. We know there's endometriosis. And then let's start talking about how are we going to treat your endometriosis. That could be the issue. That could be the reason why your implantation is lower. That could be the reason why you had the chemical pregnancies. Look at your fallopian tubes. We know that endometriosis can block fallopian tubes and that can reduce implantation rates and cause the biochemicals that you had. Those embryos could, believe it or not, be getting stuck inside your fallopian tubes, and that could make it less optimal for you. So in a case like yours, I would say embryo creation, do everything you can to create more. With the embryo transfer preparation and a patient has endometriosis, what I would do is plan your transfer protocol as if you're going to transfer, but you don't. I coordinate the biopsy for the ERA and Receptiva at the same time as a hysteroscopy laparoscopy by an endometriosis surgeon. I get the results back, and then we make plans. We talk about the surgical findings at the time of the laparoscopy, whether we should, in addition to having just done surgery, also take a medication like Lupron, because sometimes when you have those endometriomas, you also might learn that you have adenomyosis as well. and you might need more treatment for it before you transfer. So I think you still have a really good chance of pregnancy. I don't think that has changed with everything that you've shared with me. And I think that if you take these steps, what I'm hoping is that you'll have a higher chance of a healthy and normal implantation. I hope this helps. Okay, guys, I'm going to take a little swig of my coffee here. And we're going to go through your live chatted questions now. Here we go. First question is this. I've heard you mention NAD and NAC, and I'm confused about which one to take for what. Can you help clarify, please? Thanks, love you. Okay, Rima, here's the deal. NAD, egg quality, NAC, endometriosis. So if you have endometriosis, I want you to take both, right? Because endometriosis can hurt egg quality. There are people who take NAC also thinking that it can help egg quality, but honestly, I really don't want people to be taking like boatloads of stuff. Who knows if any of this stuff is really going to help at the end of the day? So I would say NAD for anyone who thinks that their issue might be egg quality related, NAC and NAD if you might have endometriosis. Next question is, how long does an IVF doctor usually follow a patient after transfer? 11 weeks, 13 weeks, 14 weeks? So I think of myself as luggage in your house. I'm always there for you when you need me. But we graduate after 10 weeks. I joke and I say, your baby doesn't fit in my ultrasound machine anymore. That's always a good problem to have. So after 10 weeks, I wish my patients the very best. And I always say to them, you know where to find me. Never say sorry. If you need me, reach out and I will be there for you and I will fight for you if you need my help. Don't let me know something is happening after the fact. Like I can't help you at that point. But sometimes I can help my patients advocate for themselves if they're not sure how to get what they need in a certain situation. I won't go through all the different situations, but sometimes having someone on your side. And I would tell you guys too that I'm not the only IVF doctor out there that's like that. So sometimes there's certain situations where having your doctor, just kind of your IVF doctor who knows you really well, because I see my patients so much that I feel like they're family to me, that I will advocate for them if they're in a spot that they need me to advocate for them. So this is from Rhea Bloom. For IVF, when do you recommend starting the 3 milligrams of melatonin? I heard 2 to 4 weeks before the retrieval. Do you test the man's hormone levels before IVF if his sperm is good? So I don't necessarily think melatonin is really that helpful for people who sleep really well. I don't see why you would need it. If you're sleeping really well, just don't take melatonin. However, guess what? These medications and the nerves and all that kind of stuff can kind of make us feel a little bit anxious. Then I'm like, please take melatonin. Like, don't worry about it. But I don't necessarily think that you need melatonin to have a good egg retrieval outcome and experience. As far as a man's hormone levels, I have the balls method. If the sperm count is low, then I would say the L of the balls method. One of the L's is labs, and that lab is testosterone. So checking testosterone can be helpful, but it isn't required for everybody. Next question is this. Hey, doctor, I have PCOS and endometriosis. I'm 25. Retrieval only ended in 3 embryos, even though I have a high AMH. The first transfer didn't work, and the second led to a miscarriage. And I also had a miscarriage with IUI. What protocol would you recommend? So in your case, I would make sure that you've done all the steps in the Angel method. Take all the egg quality supplements. Look closely at the uterus, especially at the top of it, to make sure there isn't any type of anatomic abnormality. And talk to your doctor about, have you healed my PCOS, healing, HEAL, and how bad is my endometriosis? Is it affecting my uterus? And is there adenomyosis? And what treatment should we do? That's kind of the list of stuff that I would talk about. This next question is from Sheila. Hi, Dr. Aimee June. Quick question. What is the percentage of each day 5 or day 6 embryo being normal? And is there any harm to continuing progesterone suppositories past 8 weeks up to 12? So Sheila, most doctors here in this country stay on progesterone through 10 weeks of pregnancy, and a lot of us are even going to 12. So I typically tell my patients, look, you can stop your estrogen at 10. I want you to stop your progesterone at 10, but if you're nervous, because everyone is so nervous about stopping, they have catastrophic thoughts that like something bad's going to happen if they stop, and I can't take those thoughts away. So I say, look, we'll just stay on it through 12. If that makes you feel better, that's all I care about, and then we can stop. And then as far as day 5, pregnancy rates, it really depends on the quality of the embryo, if it's normal, and your age as well, if you haven't done genetic testing. Next question is, what happens if you had a first egg retrieval with 2 embryos that made it to blast and only one that graded for PGT, that embryo didn't make it, and tested for trisomy 13? What I would say is, I think I know what you're saying. So what you're saying is you did IVF and you got 2 blasts. One blast came out with no results. It was inconclusive. And the second blast came out with trisomy. So my recommendation to you is consider doing another IVF cycle. Remember the 3 questions. What do I want? What is it going to take? And am I willing to do it? Does this one embryo help you get what you want? If the answer is yes, I'm happy with 1 baby and I already have 1 at home, or yes, I really wanted to have more than 1 baby. This makes me happy, but I think it makes sense for me to try IUIs and try and get pregnant that way first before I use that embryo, or do more IVF to get another embryo. Those are the kinds of things that I would think about. This next question is from, let's see here. I'm 39. I had 3 unsuccessful IUIs. My day 4 FSH is 11.4. It was 9 in July. I wanted to try one last IUI before moving to IVF. Is it unreasonable to think that I could have good egg quality with that FSH? Not at all. It's not unreasonable to think that at all. You are not a number, right? You're a combination of, everything. It's not just about that one FSH. It's your age, the follicle count, what your ovaries are doing that day, literally. And you just have to believe that you have a golden egg left and just keep believing. And I know that, like, when it comes to fertility, that saying, if you believe it, you will achieve it. I wish that it worked that way. But I think going into your treatment, feeling hopeful and thinking really good thoughts and believing that you have a good egg, there's something to be said for that. But at the same time, it's really helpful to have a plan. And it sounds like you do, like doing IVF next. And then also say, well, if I did IVF next and it didn't work, what I would do. So I think going from there, IUI to IVF, and then go to the next step. If I did IVF and it didn't work, it's nice to have that mantra that I shared with you guys at the beginning of the show. I'm going to be a mom one way or another. And then actually, I just forgot that I actually made it rhyme at the beginning of the show. Clearly, I forgot. I'm going to be a mother one way or another. I actually like how that sounds a lot better. Okay. This next question is, let's see here. Hi, doctor. How do you feel about transferring 2 PGT embryos for your patients to have twins? I feel like it's a horrible idea. One of my favorite patients, now one of my dearest friends, if she's watching, she's like, you're crazy. I can't believe you would say that. You helped me have twins. So the thing is that when it comes to having twins, it requires a very honest conversation about complications. And the complications that go with twins can be devastating, and they can be actually quite catastrophic. And I don't like anyone to have those types of experiences. But if someone chooses, if they say, like, look, I really want twins, I would say to them, look, this is my practice. I would transfer 1 embryo at a time. If that didn't work, 1 embryo at a time. If that didn't work, then at that point, I would consider 2 embryos for the 3rd transfer. Otherwise, it's highly unlikely for most IVF doctors to be like, I'm going to transfer 2 for you. So talk to your doctor about what their protocol is. If something like having twins is something you really, really want, remember that not all doctors would be like, I'll do that for you. Next question is, took Vitex, got pregnant. I can't see the rest of this question, so I'm going to go to the next one. Hello, Dr. Aimee. Is there a difference between progesterone that brings on a bleed and progesterone that helps keep a pregnancy? My doctor mentioned this, and I was confused. There really is no difference because progesterone in the form of, let's say, a brand name Premature, progesterone is progesterone. So we bleed when our progesterone level goes up and then comes down. So we can induce a period with progesterone, but progesterone stands for promoting gestation or pregnancy, right? And so you can also give it, because that's what it does. It promotes implantation, especially after ovulation. And then if you end up stopping it, which can be confusing, because like if I used it to induce a period and I'm pregnant and then I'm going to stop it, is that going to induce a period? And the answer is no. And I actually have patients, because my patients are super analytical and extremely intelligent. I had a patient the other day, and she said to me, Aimee, I'm pregnant now. My period's supposed to start on this day every month. I'm worried that my period's going to start on that day. And I'm like, no, that's, a period is from progesterone withdrawal from ovulation, and we're fine. We're good. But I totally understand why people would worry about that kind of stuff. Next question is, my husband's sister has Down syndrome. Should we do genetic testing? Can this be genetic? I know it's a chromosomal thing. So the answer is most Down syndrome pregnancies are not genetic, in that the parents who had the baby with Down syndrome didn't pass that on. It wasn't in their genes. However, there could be some sort of structural rearrangement that can cause it. Doing a chromosome analysis is an easy enough test to reassure you that you're not someone who can pass that on. Next question is, IUI, 3 follicles, size 25, 25, and 26, triggered today, no gonal. How likely do you think is that I'm going to have multiples? I'm 31, first IUI, and first month on Clomid, 50 milligrams. I would say you're gonna feel pretty crampy. So hydrate well, take Tylenol, use a heating pad, and hold on. Those juicy eggs, you're in for a ride. As far as your pregnancy rate with 3 mature eggs at your young age, if this is your first time ever doing something like this and the sperm is good and the tubes are open, I would say your chance of pregnancy could be up to 15%, your chance of a twin pregnancy 8 to 10%, your chance of triplets lower, like less than 2%. So let us know. Next question is, hi, Dr. Aimee, I'm 34, scheduled for an ERA and receptiva test. I have 1 frozen embryo left. If my receptiva test comes back positive, do you suggest I do another retrieval first before I transfer? And the answer is yes. You know me well. That's exactly what I would recommend. Lexington 511, hi, Dr. Aimee, is there a significant difference between estradiol and pill or patch form? So you can take estradiol as a pill and swallow it. You can take estradiol as a powder and snort it. I'm just kidding, you can't. But that's how it makes you feel. Like, it makes you feel like, oh my God, when you're swallowing it as a pill, it can really affect your mood. I would say like 8 out of 10 people tolerate it, no problem. But the 2 out of 10 that can't tolerate it, they're like, I'm having an out-of-body experience. Get me off of this. And I'm like, hold on. We have other options. You can take a patch. It has estradiol on it and put it on your skin. You can also take that pill and place it in the vagina. Who thought of that, right? I mean, that's kind of cool. And then you bypass all those systemic side effects. Next question is, in what case would you use estrogen priming in a cycle? So I rarely use estrogen priming. However, sometimes I use it if a patient will like constantly grow a follicle. Like by cycle day 3, she already has like a 15 millimeter follicle and everything's like 8 millimeters, right? I'm just like, she needs to be suppressed just a little bit. I tend to also use things like maybe half a dose of ganirelix at the beginning of the cycle, or maybe in that kind of case, consider a mid-luteal phase stimulation. Next question, would cystic fibrosis be a good reason to pursue IVF after 3 medicated cycles and 2 failed IUIs? Too aggressive? We're 30 years old and have a son conceived naturally 4 years ago. So I'm not sure what you mean by cystic fibrosis. If you have cystic fibrosis, I don't think IVF would be, I'm not sure that I understand the question. So if you can clarify it, I'll get back to you on that question. This next question is, hi, Dr. Aimee, do blastocyst rates differ by age? I heard the bag, I think percentage is 40 to 50%. If it differs by age, what's the blastocyst rate for 43 to 44? So at 43 to 44, most of the time you might not even get a blastocyst. That's the hard part. So I wish that blast formation rate based on your, could be just like regardless of your age, but you have to ask your doctor and their lab. So I quote patients about a 50 to 69% blast formation rate in the labs that I use. And I sometimes even still see that in my 43 or 44-year-olds, but I often tell my patients who are 43 to 44 that we go in having no expectations and realizing that it is very normal not to have a blastocyst at 43 to 44 years old. Can I have caffeine during my 2-week wait? I've heard contradicting ideas about this. And the answer is, if you're a patient of mine, I would say, yes, you can drink your coffee and I'm drinking my coffee and you can have it too. Coffee does not reduce implantation rates, does not cause miscarriage, and does not cause infertility. Going through this whole process, taking all these drugs can make you feel like you're in this fog, can affect your mood, can affect your bowels. And it's like, if you enjoy coffee, I'm not going to take that away from you. And I'm never going to coffee shame anybody. I've had people say to me like, I did my transfer, it didn't work. It's probably because I didn't drink coffee. I was drinking coffee. I'm like, wait, what? Like, no, that's not how coffee works. However, I understand that you might be seeing an acupuncturist that might make you think that every time you sip of coffee, I don't know why I said it that way. Every time you take a sip of your coffee, that it's like you're drinking poison. And I promise you, that's not what happens. But you know that saying, everything in moderation. I mean, if you're drinking coffee like me, which is like 7 cups of coffee a day, because I have to stay on task. Not that I have problems staying on task. I have to stay focused and be able to accomplish all the things that I need to accomplish in my day. And I can tell you that caffeine really helps me, but don't have 7 cups a day. And maybe I don't have 7 cups. Maybe it's like 3. It's probably 3. But I would say, no more than like 1 to 2 cups per day. After transfer, I would say you're going to be fine. Let's see here. When you use a sperm donor, do you still use the balls method? And the answer is yes. You want to look at the genetic part, background genetics of the sperm donor. There's like this pandemic, if you haven't heard, right? But it's not a pandemic with COVID. It's a sperm pandemic with sperm banks, where sperm banks are running out of sperm left and right, and they can't keep up with the demand for donors, right? And so you want to look at their background genetics. You want to look at your genetics to make sure you're genetically compatible. almost all sperm banks, if not all, are looking at chromosome analysis and carrier screening. They're not doing all the other stuff like testosterone levels. They're not making sure the sperm donor is in great shape, taking supplements and stuff like that. But you can look at their profile and see, right? So take a look at their body size, take a look at their habits and see what you think. Look at the age of the sperm donor before you pick them. But yes, you can't necessarily do the whole balls method, like look at their balls, for example, and see if they have a varicocele. But there's a reason why they're a sperm donor, and that's because they basically qualified based on their sparkly sperm. Next question is from Caroline. I just found out that I have 2 bilateral endometriomas removed. One was 7 centimeters and one was 5. Will this be devastating to my fertility, or will IVF still be an option? So Caroline, get your AMH checked. Test, don't guess. Find out from your AMH what your fertility levels are. Talk to your doctor about your follicle count and make a plan. That's the way to go. That's what I would do if it were me. Don't sit here wondering and guessing and worrying. Let's get some answers for you right away. Chiquita is saying, is there a diet you would recommend prior to IVF? Ketoacidosis, maybe? I would say I recommend a diet that you're going to follow. A plant-based diet is really wonderful with protein from plants. If you're going to eat meat, no problem. Choose organic and lean meats, for example. Work with a nutritionist. I have a fabulous nutritionist that I refer my patients to. So talk to your fertility doctor and be like, who can I talk to? If you haven't seen foodfuels.com and Coach Nina, that's a really good resource as well. And Judy from Mind Body Nutrition, she's fabulous as well. And I have my patients work with Linda Michaelis also here in the Bay Area. Next question. I'm 31 with an AMH of 1.2, FSH is 18, antral follicle count 8 to 9. With previous implantation issues starting a new cycle, my doctor recommended gentle stimulation to get 6 to 8 follicles over, I think I know what you're saying. I like that idea. I mean, I don't know what your embryo quality was before and how many embryos you got, but if your doctor thinks that they have a protocol where they can get the same amount of embryos and they'll be sparkly, then go for it. I mean, 6 to 8 mature eggs still sounds pretty darn decent. So I have no problem with that. Next question. I'm 44 years old. My doctor is canceling my IVF cycle due to poor response. Is it possible to trigger my period faster so I can do one more cycle before the lab closes in early February for vacations? The answer is you don't need to. Talk to your doctor about trying DuoStim. Just be like, I talked to my friend who did DuoStim. I'm just kidding. Don't lie. Just be like, hey, I was online and I saw this fertility doctor talking about duo stimulation, and go in and see if you're a candidate for it. And what I mean by a candidate for it, you guys heard my riding the wave analogy, right? We have these waves of eggs and you want to see, should I ride that wave? And you never know if you can catch the wave unless you're watching for it. So watch for the waves. And the way that I watch for waves around here are ultrasound waves. You guys, I'm on a roll right now. Like, don't break this roll. So you look for the ultrasound waves with Wanda, the pelvic ultrasound probe, to look at your ovaries, take a look and see how many follicles you have, and then decide if this is a wave you need to ride or not. So that's one strategy so that you're not waiting for your period to start before the IVF lab closes in your area, and it sounds like they're going on vacation in February. Who goes on vacation anyways? Next question is, what are your thoughts about clinical trials to help getting IVF at an affordable cost? I don't know much about, no, I know much, but I don't know many or any IVF trials right now to get at an affordable cost. However, if there is one out there, I can promise you that they want to do everything possible to get everything right from start to finish, and they're going to be super meticulous because it's a trial. So if there is a trial out there, sign up and make sure you have all the information to feel like you have informed consent. Next question is, if you don't take progesterone pessaries at the same time each day, can that cause implantation failures? And the answer is probably not. I mean, I don't know much about pessaries, and the reason is in this country we don't use pessaries. We use these gross suppositories that like cause this vaginal slime, and that's called crinone and endometrin. So I tell my patients, you got to be very strict, 8, 2, and 8, or else 8, 2, and 8, and don't be late. And if you're late, your efforts could be done. So like I scare the heck out of my patients so that they have like 20 alarms going off. Their partner's alarms going off, their neighbors are knocking on the door, their mothers are calling them. Did you put the endometrin in? That's how serious I want my patients to take it. I'm not sure how strict you need to be with the pessary. Next question is from Vienna. Dr. Aimee, my doctor wants to add growth hormone on my second cycle. On my first, I had 22 follicles, 10 eggs, sadly 2 blasts, and they were abnormal. Do you think it would help? In Vienna, I would say yes, it could help. So consider doing it, realizing that it might not help, but it still may help. And look at the sperm, make sure it sparkles, look at your lifestyle, make sure you're as healthy as possible, look at your supplements, see what you need to take, make sure you got your fertility team around you, your therapist, your eating coach, your exercise coach, your acupuncturist, your mindfulness coach, get it all. And guess what, guys? You don't need to go anywhere for any of that. Okay. Next question. I'm struggling trusting my FET will be successful. I'm 39 with one normal frozen BC blast and a standard protocol from my doc who doesn't recommend the receptiva test advice. Okay, so with the BC blast, you have to ask your doctor, what is the likelihood that this blastocyst is going to implant? At BC, the quality in my lab would be extremely low. So you have to talk to your doctor about what their expectations are as far as implantation rates and make sure you really understand. Because imagine you go into a transfer and you're like, I expect this to work. And even when you expect it to work and it doesn't work, it's horrible. But if you went in expecting it not to work less than 50% of the time and it didn't work, you're not going to be like, I wasn't surprised. But at the same time, you might want to know that ahead of time because guess what? You might want to do another cycle before you transfer. So next question is ICSI a good idea after 2 IVF cycles? I don't usually pick the procedure of ICSI based on the number of IVF cycles a person has done. ICSI, for those of you you guys don't know, is the procedure of picking the most sparkling sperm out of the batch and injecting it into each egg. So remember, diagnosis before treatment. So if sperm quality is low, if you've never had fertilization before, consider ICSI, or if your doctor thinks you need it. Lizzie says, do people that have a subchorionic hemorrhage have to worry about miscarriage, diagnosed with one at 7 weeks and have had 2 bleeds with clots, babies measuring on time with the heartbeat? And Lizzie, no matter what I say, you will be worried. Anything that starts with hematoma or hemorrhage is going to make you worry. So let's call it a hematomato. When I have patients that have one, I say, look, just relax. Who am I kidding? Rest up and realize every time you see spotting or bleeding, you're going to be worried. And that's normal. It would be really weird if you're like, oh, I'm pregnant and I'm bleeding. And, oh my God, I'm so not worried, right? Like, who does that? No one that I knows. No. So I often try and reassure my patients by doing ultrasounds at regular intervals if you have a hematoma so that I can tell you everything is literally okay and everything will be okay and you're not going to miscarry as far as I can tell right now. Okay? Hope that helps. This next question is, thank you for answering my last question. I was wondering what you recommend instead of Menopur. I had problems with it stimulating my eggs. I also kept getting recurrent BV. What do you recommend? So as far as Menopur, you can just use Gonal-f alone. You don't need to use the Menopur. Yeah, and as far as BV, I would get treated. You can take Flagyl. I'm not worried about how that would interfere with your stimulation. Next question is, I was on esterase priming and cetrotide for priming and started my period, finished priming despite my period, and now my doctor's having me start stim meds on day 6. Should my period during priming hurt the cycle? So I get it. So you're on cetrotide as part of your priming. So just get the whole thought of being cycle day 6 out of our heads. And the reason is that they've basically kind of taken over your cycle. And by taking cetrotide at the beginning, you're not really cycle day 6. So I'm not worried about it. Next question. I thought melatonin was recommended for egg quality. Is that no longer found to be true? And the answer is there's so many things that you can find online that might not be true. Sleeping well, getting good sleep, circadian rhythm that's normal, help egg quality? Seems like it. Do you really need melatonin if you're sleeping well? Is that really going to help your egg quality? Who knows? I'm thinking probably not. But if melatonin gives you a really nice deep sleep that you're not getting without melatonin and you're preparing for an IVF cycle, I would take it if it were me. Next question. I have cystic fibrosis myself. Got it. I was told my cervical mucus is not thin enough for conception, but IUIs have not worked. Should we try another IUI or move on? My AMH is 1.65 and my hubby's morphology is 3.5. And I would say, yes, thank you for clarifying that question. I do think that doing IVF would make sense. Go for a nice gentle stimulation so that your ovaries aren't too swollen, that they can somehow push on your diaphragm and cause problems breathing. And then get an anesthesia consult, talk to MFM, do all the things I'm sure you've already done before, because I think what you mentioned in your question earlier that you might already have one baby. Next question is, what would be a normal follicle count on day 10 for a 38-year-old with normal hormone levels and no medical conditions? I would say around 6 would be pretty average for a 38-year-old. Coming in around day 10, 6 to 8 would be pretty average for someone who doesn't have any fertility issues at all. Next question is, what are the optimal estrogen levels for an FET? Medicated cycle day 7, estradiol 2100. Is it too high? 2100 is a little bit high. What are you on? crack version of estrogen? I'm just kidding. I've seen it high before. Some people can respond really quickly like that. Excuse me. But I would say at 2100, you're probably feeling super symptomatic. So talk to your doctor about taking it down a notch. What are the oh, I already answered that question. Let's keep going here. Could you explain what is duo stimulation about? It's literally that, duo, two, stimulation, two different times. Stimulate the front part of the cycle, stimulate the end part of the cycle, and then you also can just stimulate continuously. So stimulate egg retrieval, don't stop, stimulate egg retrieval. And there are reasons why you do that. If someone has cancer, they're running out of time because of age or because you just want to. I wouldn't necessarily do it that way. I'm not recommending it, but that's what you asked me is to define it. Okay, guys, we're almost done. Last two questions. Here we go. The first one is, what should optimal levels be prior to FET, including the uterine lining? I like a level around 200. Next question is, and it could be more. I have patients at 400, 700, 900, 150, just like in the hundreds. Next question, is ovarian drilling dangerous? No, ovarian drilling is actually quite brilliant. It is a way to lower testosterone levels at the level of the ovary to get women to ovulate again. It's not dangerous. It's used in other countries who don't have access to lots of treatments that we have here, like IVF, especially in women who are Clomid resistant and have PCOS. Women who have ovarian drilling, sometimes their ovaries just start working again. Okay, guys, you guys are the best. Thanks for listening. Thanks for joining me. Send in a question at asktheeggwhisperer.com, and I'll be here again probably tomorrow. I hope so, because I love answering your questions. Have a great night, everybody. I'll see you guys later. Bye-bye.